So I'm going to introduce you to some concepts of subthreshold laser. First, these are my disclosures. Notice that one of them is Quantel Medical, which is one of the manufacturers of laser. So a little bit about nomenclature. So subthreshold just means that it is not visible. We are all used in training that when we do laser, there's usually a visible burn. When we talk about subthreshold is we do not want to see that visible burn. This technology has been available for the past couple decades, so it's nothing really new, but there are certain terms that we need to define. So one of them is micropulse, and micropulse is a term that is patented by Iridex, and it was used sort of synonymously with subthreshold, and they actually licensed the use of the word micropulse to other laser companies, but at some point they decided they didn't want to license it anymore. So that created a little bit of confusion because other companies also had laser machines that did the same thing, but they didn't have a name to that. So that's where the term subliminal that has been used by Quantel Medical comes into it. But in essence, subliminal micropulse refers to the same technology. So why are we talking about this? You can see here, this is a patient that had laser photocoagulation, macular laser photocoagulation, diabetic patient. And you might say, wow, these are really big burns. But in essence, what happened, these were done with ETDRS protocol, small burns that over time, they expanded. So the purpose of subthreshold laser is to eliminate the iatrogenic damage from conventional macular photocoagulation. And here, when we talk about conventional laser photocoagulation, I'm referring to continuous wave photocoagulation. When we talk about conventional photocoagulation, you will recall that when you set your parameters, you have a time. And that time, once you push the pedal, will remain, the power will remain on for whatever power you choose to. So if, for instance, you say 200 milliseconds and you press the pedal, the power delivery would be whatever watts you choose for the entire 200 milliseconds. And that is a problem because you can create the burns that we want to avoid. Here is a chart where you can see that if we target the RPE, and we want just to limit the energy delivered to the RPE, we can reduce the exposure times, and you can see we have a tighter target once we make the time less and less. If the time is wider, we also affect the choroid and the retina in the vertical direction, and also laterally, we are also expanding the heat wave. When we talk about subthreshold, again, it means that there's no visible reaction while performing the laser. And the subliminal or micropulse is that in contrast to the conventional photocoagulation, what we do is that this pulse of energy, we break up into lots of mini pulses, and depending on what duty cycle we choose to, the power will remain off just a percentage of the time, and the rest of the time, the power is turned off. So this allows us to treat more targeted the RPE, allowing us higher powers because we have time to let the tissue cool down and not have the problems that we have with conventional long wave photocoagulation. And this is a macular treatment. So again, this is what we do. So this is the entire pulse, and you can see here that the power is turned on only for a fraction of the entire pulse, whereas the majority of the time there is no power delivered. That allows the tissue to cool down, and there is no iatrogenic damage. perceived in the tissue. And I mentioned duty cycle. So the duty cycle is just the time that the pulse is on compared to the entire time. And you can see here the definition. And what we advocate, and Jay will talk about, is a duty cycle of 5%. So this means that when we have the entire pulse, the laser is actually delivering energy only for 5% of the time, and 95% of the time it's off, and that allows the tissue to cool off. So one of the key things about micropulse is that we want the low duty cycle life 5%, and emphasizing again, because of this time that we allow the tissue to cool, we don't get into problems with iatrogenic damage, particularly since we're working in the macula. So the ideal subliminal laser of the micropulse laser is yellow wavelength, that it has multi-spot technology or patterns and a low duty cycle. Let me go through this. Wavelength, does it matter? Yes, it sure does. Here we have extension curves, and there are several pigments here: melanin, the hemoglobin, and the oxyhemoglobin. And you can see that in the macular area, we have the xanthophyll, which is present. And if we use a green laser in the macular area, some of that xanthophyll will absorb the heat. So probably this is not the best laser to work in the macular area. Whereas with the yellow here at 577, we have good absorption curves in melanin and also the hemoglobin, and there's virtually nothing in the xanthophyll range. So to obtain the best results with the maximum efficacy and safety, the ideal laser should have uniform thermal effect, good penetration through opacities, and low energy absorption by xanthophyll, like I mentioned. So yes, it does matter. The best is 577 because also it allows us to titrate the power directly under subliminal or micropulse mode, which allows us to reach a visible endpoint. Jay will talk about this in more detail in his talk. But in essence, you know, the first micropulse and lasers that were created were 810 nanometers. And because it was in 810, it was really hard to titrate the power under micropulse mode, and that made it that you had to take an extra step, titrate under conventional photocoagulation mode, and then you had to turn it down to micropulse. But sometimes people forget, and you got into trouble because you were treating the macula with the full dose in the macular area if you forgot to do this. So it is safer to do that with the yellow laser, and you can titrate directly under the micropulse or the subliminal mode, making it safer. The other point I want to talk about is the multi-spot or the patterns. You will recall that the laser works with a motor that moves a mirror, and that is how we get the different burns in a set pattern. And this is important because of the movement of the motor. There's a finite number of spots that a pattern can have. This is also important in the micropulse mode because it allows us to do confluent laser therapy. And there's a lower risk of undertreatment with multi-spot. You can imagine if the burns are invisible and we want to do a dense treatment, and when I talk about dense treatment, is that you have one burn next to the other, with no spacing in between. If the burns are invisible, it is really hard, or I would say virtually impossible, to get that type of pattern. So the most common cause of treatment failure is undertreatment. So let me emphasize that it is important to have the patterns or the multi-spot in order to do this type of treatment. Many years ago at Arvo, Victor Chan did this study looking at different duty cycles, different wavelengths, and he found that even though we're talking about subthreshold laser, there was still maybe some type of damage, iatrogenic damage, if you didn't fix the parameters. And in rabbit eyes, he showed that the last damage was using the yellow laser at 5% duty cycle. So in the treatment guidelines, Jay will talk to you about this in more detail. We can use large spots because there's no intended thermal injury. Large, so 160 micron spot size are used in order to increase the treatment area and to ensure dense delivery of the laser impact. So for those of you who are older and remember doing the focal laser, you might say, wow, 160 microns, that's really a large spot to work in the macula. We're used to like 50 to 100 micron sizes. But the problem, the reason for this is the following. So here is a grid of 25 spots of 50 microns. And if we want to do a dense treatment, we will need 81 of these spots. And now remember, this is a pattern that needs to be moved with a motor. So patients cannot keep their fixation steady for that long in order to finish this pattern. So you can also do these 25 spots using 160. So that's the reason why we use the spot size of 160. I'm going to skip through this because Jay's going to talk to you about this. So in summary, the key characteristics of an ideal laser for macular work is that it has to have subliminal or micropulse mode. We talked about the importance of using multi-spots or a pattern and the importance of the yellow wavelength. Thank you very much for your attention.
Thank you so much, LihTeh. Very lucid talk with clear messages. I just have one question that, means over the years, we learned that we started with 890 and then came 577. So do you have any preferred choices for different wavelengths? Like, if you're dealing with more of a diabetic macular edema, you prefer certain wavelength, or for something more RP-based diseases, you prefer something else, or one wavelength in your opinion?
So I think in essence, if you're experienced enough, it doesn't really matter because energy is energy. But in terms of ease of use, I find that the yellow one is more user friendly because like I mentioned, it's easier to titrate. There are some schools that don't like to titrate, but remember, this is all the heat is absorbed by the melanin. And when we deal with people from different races, we all have different types of pigmentation. So I think you need to personalize that treatment. And I think with the yellow, it's a little bit more versatile and allows you to do that.
Yeah, I agree. And with having practiced in India for almost 9 years, I can see the difference and how even the same Nevela subthreshold, which I used to use, that's really different. But yeah, we'll go on to Veeral's question for you. Veeral, please go ahead.
Yeah, LihTeh, great talk. I have a couple quick questions. Do you approach different disease states in a different way? In other words, if you're treating DME versus CSR, do you change any of your settings or do you change kind of the area that you're treating? And just briefly, because I know we'll get into this at some point, but what types of cases are you routinely treating with this?
So that's a great question. Most of my work has been with CSCR. Many of you know that perhaps for CSCR, PDT was our #1 treatment, but here in Costa Rica and the rest of Latin America, we haven't had Visudyne for the past 10 years. So that's why we evolve into using this laser, and it works very well. We normally, or personally, what I do is I use ICG or FA to guide the treatment, the areas where you see the hyperpermeability, and those are the areas that I treat. In DME, there are papers that show that, if the central macular thickness is greater than 400 microns, the laser doesn't work that well. So I usually try anti-VEGF, try to get the maximum effect of the anti-VEGF. And for the residual, if it is less than 400 microns, I use the micropulse laser, and I use OCT guided, not the FA, and treat all the thickened area.
Great, thank you so much. Supriya, you got some questions? We can't hear you.
Hi. Yes, my question is that there are different strategies to go into micropulse mode. Like, some people titrate in the micropulse mode and then bring it down to 30%. Or the other way you mentioned is titrate in the continuous wave mode and then, then change to micropulse mode or double the power or something like that. Any difference in the strategies? Does it make a difference on what strategy you follow?
So again, with the yellow laser, it is easier, so I don't have to deal with continuous wave. So I just turn on the laser under micropulse mode, and then I treat until I get a barely visible lesion, and then I turn down the power to 50%, and that's how I do it.